Well, thank you very much. And being the last witness of the day, I will try to not repeat everything that everyone else has said. And what I'd like to do is, I agree with everything Ms. Ignani has just said, except that I do want to say one thing, and that is that the details do matter. And one of the things that our members do for a living is we look at a lot of the details. And I feel it incumbent to bring up a couple of those, because I think we do need to make sure that we get these things straightened out before we move forward. And I do want to stress that we don't want to not move forward. We want health reform and we want it done correctly. But I do want to mention a couple of things to illustrate to you that we've got to get some of these things that may appear to be small straight, because they could have huge implications. First of all, I want to mention the rating provisions in the bill. And I want to stress I'm not talking about the no pre-existing conditions. I'm not talking about the no health status rating. I'm not talking about anything like that. I'm talking about specifically the modified community rating provisions. Currently, the bill uses something called an age band of 2 to 1. I'm not going to go into details about that except to tell you that it's too narrow. And Mr. Chairman, I'd like to use your own state for an example of it being too narrow. New Jersey this year recently went to 3.5 to 1 age bands because what they had was too narrow already and it wasn't affordable for people. The gentleman on the last panel that talked about New Jersey rates of $13,000, they're in a situation of 2 to 1 age bands, and that's one of the reasons why it's too expensive. So we want to make sure that we establish bands that allow wide enough adjustments to make it affordable for more people so that we don't end up losing a lot of the young person participation. In addition, one of our very specific concerns has to do with the fact that this bill tends to lump all groups that are what we call fully insured together, whether they're a group of 10 people, 50 people, or 200 people. And the modified community rating provisions apply to all of them. Today, groups of over 50 on a gradual basis use their own claims experience. And when I talk about claims experience, I don't mean prospective health status rating where they fill out a health statement in advance. I mean that the group develops community rates based on the experience of their own group of employees. It's very cost effective. It allows them to keep their rates lower over time. And I would point out, this is not a market that has problems today. These are not the people that are knocking on your doors telling you that they have a problem. And I would encourage you to not eliminate that ability for them to do that, because the rate shock to the employers and employees in that category will be fairly significant. I would also like to point out that the grandfathering provisions really need to be improved, and there are a couple of areas that I'm thinking are probably just mistakes. It's a draft inside the bill that ought to be changed. The provision, first of all, is too strict for individuals. It only allows them to add family members, and frequently these policies are reviewed on an annual basis and other minor adjustments need to be made. For example, a person that has an HSA qualified plan has a legal adjustment to be made relative to the deductible on an annual basis, and the bill doesn't really allow for that. And then groups, of course, are not really grandfathered. They have a phase-in period over 5 years, and we would be hopeful that groups could keep their coverage longer than that period of time. The one thing I want to talk about that I don't think anyone else has mentioned has to do with risk adjustment. This is something that we look at a lot. We're very involved with risk adjustment and reinsurance inside plans to make sure that they're stable. I'm very concerned that the risk adjustment that's suggested is not adequate for starting up this program. The risk adjustment suggested is more something you would do once your exchange had been in effect for a period of time, and it would adjust risk among the plans inside the exchange. It doesn't account for what's going to happen initially when we have lots of people entering the system, many of whom may have serious health conditions. For example, the way your bill is written today, on day one of guarantee issue, every single person in this country that's in a high-risk pool will come immediately into that pool. So we've got to have something to mitigate the cost of those high risks coming in so that you don't end up with something you don't want, which is a pool that results in costs that are higher instead of lower. And so again, these details are important that we get them straightened out correctly. I would be remiss if I didn't say something else about the public program. Like many of the people that have talked here today, we are very worried about a government-run public program. I want to talk specifically about the cost shifting. There are a lot of things that we have concerned about, but we do definitely see the impact of cost shifting. You know, we've all heard this statistic, but I think it bears repeating again. Almost $1,800 a year for the average family of 4 is a direct result of today's cost shifting without a new public program. And I want to mention one other thing. I see that I'm out of time, but I want to mention this very quickly. We've heard state premium taxes mentioned here many times today, but I want to kind of put a face on that because in New Jersey alone, state premium taxes are $503 million annually to the state, and they are not dedicated to insurance. They fund other programs. We have programs in North Carolina, Connecticut, Kentucky, Pennsylvania, North Dakota that where state premium taxes fund firefighter programs. They buy equipment to fight fires. And so these funds are, I don't think the states can do without this revenue source. And it's another example of how we're not going to have a level playing field, and we need to think this through a little bit more carefully. And I have additional information, but I'm out of time, so I'll go ahead and stop now.
Thank you. And, you know, as I mentioned earlier, I think I did, that whatever your written testimony is, or, you know, data that's attached to it, we'll put it in the record in its entirety. I wanted to, let me start with Ms. Politz. The discussion draft takes the step of prohibiting discrimination in insurance based on a person's health status, things such as disability, illness, or medication history. However, you know, as we're trying to close the door on that with this bill, some are proposing others, and I'm not entirely sure what you said, but I know that you said that, or at least in your written testimony, that insurers should, I'm talking about Ms. Trautwein now, that insurers should continue to be able to alter premiums based on a person's past claims experience. And the way I understand it, that employers would be permitted to change a person's premium, not necessarily on their health status, but on certain activities like wellness programs and those kinds of things. I don't want to put words in your mouth.
Can I explain what I meant? Because that is not what I meant.
Sure, go ahead.
We want health status rating to go away for
right.
individuals.
But you said that the employers...
We're talking about employer groups where they look at all of their employees, de-identified information.
Right.
And they calculate what their anticipated claims are for the next year. This is done all the time.
Right.
And then they figure out how much they need for reserves and things like that, and they develop a rate based on their particular group. And it's a very, very cost-effective way of doing it. It results in lower rates for the employees, not higher. That's why we were asking for that. I just wanted to add to that there is language in the bill that after a period of time, even employees that are a part of a program where there is an employer-sponsored plan can elect to spin off of that plan to go into the exchange. This is a direct threat to employer-sponsored coverage. We're very concerned about this because you have to maintain a decent participation level inside an employer group to have that balance of risk that I was talking about earlier. So I think that is something that we should really look at, whether that's a good idea to keep that in the bill language.
Yeah, I guess my time's expired. Can I just ask one other question? I know you've been here for hours, but just one other question. Ms. Trautwein, in your testimony, you talked about it's critical that there be a financial backstop to accompany reforms of the individual and group insurance markets. And I was curious, now what do you mean precisely by backstop?
Well, it could take many different forms. It's kind of what I talked about earlier, this idea of reinsurance. You know, some states today use a high risk pool to backstop their individual market, but it doesn't have to be that. It's just something to make sure that we address the cost of high risk individuals. This is a particular problem during the first 5 years, I'm guesstimating that amount, because it's going to take us a while to get the hang of this individual mandate and enforcing it. We won't have everybody in overnight, and so there will still be initially adverse selection, the same that we have today in this market, and we've got to do something to make sure that those high-cost cases don't make the cost of coverage go up for everybody else. So we're not trying to wreck the proposal. We're saying you need to add this thing in here to stabilize your proposal so you will not have these unintended consequences.
Thank you, Mr. Chairman.